We're resuming our hearing of August 5th, 2025. We have a presentation and a budget hearing relating to SVMC's fiscal year 26 budget request. I'll ask that our counsel, Mr. Henksler, swear in the witnesses, and after that, I'll turn it to Mr. D and his team for the presentation.
Good afternoon. I'm going to have the folks representing SVMC unmute, and what I'll have you do is I'll read the oath for witnesses and then ask you each to individually state your name and say I do, and that way we have a record of each person. Okay, so the oath. Do you solemnly affirm that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth under the pains and penalties of perjury?
Yes, Thomas D., I do.
Robert Lava, I do.
Trey Dobson, I do.
You're now sworn in. Go ahead.
And I think Tom Green probably has to swear in too.
Sorry, Thomas H. Green, 3, I do. Did that come through? Sorry, I'm more of a Zoom guy. I'll get the hang of it, Chair Foster, I promise.
Thank you. I'm sure you will. So we'll turn to you, Mr. D. And again, thank you and your team for being here.
Thank you very much, Chair Foster, and welcome also, and welcome the new members to your board. So again, my name is Tom D. I'm the President and CEO of Southwestern Vermont Medical Center, and I do want to mention from our team who will be presenting today, which was Robert Lava and Trey Dobson, and also Tom Green. And Tom, you probably have not met Tom before, but he is our chair of our board. And I thought it'd be interesting and good for the board to have a name and face to who represents our community and our board. And I think Tom we're very, very fortunate to have him as our chairperson. And he's indicative of the committed and dedicated and talented group of individuals that serve on a tireless nature on our board, serving our health system in our community. So thank you, Tom, for being here. And certainly, this is a very challenging budget for SVMC. I've been in the field for over 45 years, and I always say, hey, things can't get tougher. And they get tougher each year. This is probably I would say this is probably the toughest budget we had to deal with in my 45-year career. And I do appreciate the work of the Green Mountain Care Board. And I realize how difficult your responsibility is given the challenges that we face in the state of Vermont. Our organization, SVMC, we value the relationship that we have tried to build over the years with the GMCB. We've tried diligently to follow the guidelines that you establish each year. They get more challenging, and we expected that. And we try to keep an open line of communication with the board and with your staff, which we appreciate their work too. We try to live by the philosophy of no surprises, and sometimes that's challenging, but that's how we try to do our day-to-day operations, as well as working with our regulators. Our hurdles are really incredibly significant this year through our budget process. We are dealing with the major impact of H.266, as well as the impending loss of our eligibility for our 340B drug discount program, which we'll talk about in more detail. But our organizational membership in Dartmouth House is truly critical to our strategic initiatives. And our initiatives directly tie into the Oliver Wyman recommendations for SVMC, which again, we'll talk about more in our presentation today. We have historically been one of the lowest cost hospitals in Vermont and within the tri-state region. And again, I think that was reaffirmed just this year by the Loan Institute, ranking SVMC first in Vermont for value of care. But we also realize we must do better. We can't fall on the accomplishments of the past because that will not be enough to carry us into the future here. The environment's different, and we realize that. And our strategy is to become more affordable. And this goal directly relates to our strategy that we created with Dartmouth Health to ultimately become a regional referral hospital within the DH system. And we feel strongly that we can reduce our patient out migration, the people who leave our region, and they leave our region for care. They go elsewhere out of state oftentimes. And these are Vermonters. And our goal is to be able to serve their needs and the purpose of serving their needs. And we think doing that will help us reduce the cost of healthcare for Vermont, because our costs are lower, quite frankly, than our region that we deal with. And I think our outcomes are as good or as better than other providers too. So the value equation of providing high quality care at a lower cost is what we're striving for. So let me just take an opportunity to give you a short overview of SVMC, especially for some of our new members, and just to describe our institution. This won't be a long process, but so here's a regional picture of our tri-state region, which we locate our outpatient clinics. And again, we find it very important that we go beyond just Bennington, and we service our communities. We are looking to expand our footprint. We're looking to expand beyond our current primary and secondary area of about 75,000 people, and we think we can expand through a strategy of service enhancements to treat about 125,000 is our goal. Next slide, Bob. Next slide. Oh, thanks. So, quick profile. We're over 100 years old. As I said earlier, we serve 3 states, and we're small, but in Vermont standards, we're fairly sizable, 15th largest employer in Vermont with over 1,300 employees, and a medical staff of over 200. And I think it's noteworthy that our medical staff is 100% board certified. That's a requirement, certification in the area of their residency training. And I think there's a statement of the quality that we place upon in terms of our providers who work for us. And it's a challenge for a rural hospital to do that, but it's one which I think is indicative of SVMC. Next slide. And I'm not going to go through all these, but it's just indicative. Our vision of SVMC is to be recognized as really a preeminent small rural hospital system that provides exceptional convenience, safe, and affordable care. Those are the four descriptions we have in our vision statement. And it's something we continue to strive for. We're not where we want to be, I'll be honest, but from a Medicare standpoint, we're always a 4 or a 5 out of the last 5 years. We've been one of those rankings. We are Magnet certified, a 5-time consecutive Magnet Award winner, going for our 6th in September, and we know we're going to get it. We have a full recommendation from Magnet, and that will make one of 2 in all of New England in terms of a 6-time award winner, and a small number across the country. And I should say we're also the smallest one in the Magnet Award winning hospital in the country. We strive for excellence in all our departments, and recently our ER just was recognized as a Lantern Award winner, the first hospital in Vermont, and only one of 93 for outstanding clinical and nursing care. And the American Hospital Association recognized us a few years ago as their award-winning hospital for community leadership and in collaboration. And that's kind of the philosophy of how we operate. We realize we cannot work in a vacuum. We're not large enough. We're not strong enough. We're not smart enough. We need partners, and that's how we do our business. And certainly other things in terms of our quality of care. So Trey, I think I'm going to ask Trey to talk a little bit about quality right now, and I'll come back and make some more comments.
Great, thanks, Tom. Trey Dobson, I'm an emergency physician and the chief medical officer at SVMC. Just a couple of things on quality. I threw this slide up. Tom had mentioned it already. It's the CMS Gov structure that you're most all familiar with. But why do we focus on this? Well, it's one of the best ways to look at outcomes. And right, outcomes are what drive our staff to work. It's what gives them the motivation and the inspiration to do what they do, is to generate good outcomes. And that's what they want to see. They're not as concerned about what we're doing here today from a hospital budget standpoint, but this is what drives the purpose behind what we do. And you can see the measure groups. Again, you're most likely familiar with it. And SVMC has had a 4- or 5-star rating for the past several years. And all of those measure groups on the side, those are things that really matter to people. Thanks, Bob. Go ahead. And then I won't go through this slide much, but Tom had mentioned the Loan Institute, social responsibility. I think that's incredibly important in medicine, and SVMC has an A score. And finally, we talk a lot about patient experience and how patients rate their time in a hospital or in an outpatient practice or their encounter, which is incredibly important. But just as important, truly just as important, is what does the staff feel about the care that is delivered in their organization? And I think we all know this. You might ask your neighbor who's a nurse or your doctor, hey, if you had to see XYZ, where would you go? And they're very honest with you because they tell you what they think. And at SVMC, we do our employee surveys like most every place, and we score extremely high on safety. The staff here think that we deliver high quality, safe care. And I tell you that matters a tremendous amount to me and to all of us. And then next slide. And I think I'm passing that back to Tom.
Yeah. Thanks, Trey. So a one-pager, just kind of, this embeds our strategic plan in terms of where we want to go as an organization. And, if I just highlight the far right, which is the evolving towards the goal of really becoming much more of a value-based organization focusing on population health. We realize the current model is broken, and we need to evolve towards how we care for our people and how we keep them as healthy as we can. And we're proud of the work we're doing there. We know we have a lot more work to be done here, but on the other columns there are really the areas that will help us to achieve that population health and to become sustainable. And that's advancing our clinical systems of how we need to expand certain key service lines, and realizing under our operations management that we have to become efficient, we have to reduce errors, and we have to, certainly create more technology to do that. So these are some key initiatives that we're focusing on. And of course, the purple column is the infrastructure. I mean, we have a challenge. We are the oldest physical plant in Vermont in terms of the age of facilities, but we're trying to slowly upgrade the facilities as well as the technology and as well as certainly our IT systems, which we all have major investments to do, and it's not going to be inexpensive. So our board, certainly continues to ask for updates and to see how we're going to get that journey towards updating our physical plant. And we've been, with the Green Mountain Care Board's oversight, we've been making some strides there just recently, updating our emergency room, which is a critical service, and also becoming the workplace of the future. The magnet designation is an example of what we're trying to do. And we're trying to create that throughout the organization and creating various pipelines, both for providers as well as clinical staff and support staff. Next one, Bob, next slide. And that ties into our longer term strategy with the Dartmouth Health and how we're looking to integrate. We became a member hospital of the Dartmouth system back in 2 years ago in July of 23. That was after a 12-year stint as an affiliate member. So we really had a courtship for 12 years to learn about their systems. They learned about us. Again, no surprises as we entered into the system, and we became the 6th member. And of course, now, as you just heard from from Mount Scottney and Valley Hospital. Valley Hospital now is a 7th member. And we're looking to integrate as much as we can in terms of our clinical and administrative operations, because we think that will certainly play a major role towards us becoming more efficient in our operations and to share costs. And this is just a picture of Dartmouth, as well as a map of where the various hospitals are. Next slide. And with the idea, as I said earlier, to become a regional referral hospital, we think that we know that Dartmouth has many patients in their institution, especially from Vermont, who really don't need to be in an academic center, but they're in Dartmouth, and we think we can care for those patients in the community hospital setting with the appropriate services, backup services. And so over the next 3 to 4 years, you see on the right-hand side of this screenshot a number of key areas that we are looking to focus on at SVMC, which will help drive our ability to take on additional patients and also to reduce the outmigration, the patients who are leaving the Southern Vermont region for their care elsewhere. We think, with this type of upgrade to our services, we can care for many of those individuals. So, but we can't do it without Dartmouth. I mean, that's a key piece of our whole strategy, and something that it's paying dividends as we speak in terms of the services that we're trying to provide for the future. Next slide. I think back to Trey.
Yeah, so thanks, Tom. So primary care access, I'm just going to talk about access in general, primary care, and then specialty. We're not where we want to be at all with primary care access. And we can talk about how no one is and how this is so difficult around the country, but we don't want to be making excuses. We want to focus on what can we do to improve access in this area. And that's not just recruiting in new people. I mean, that is a big part of it, but it's also efficiencies. It's also innovation. How can we get more people the care they need? So some of the things that we've done, though, is we just finished doubling the footprint of one of our 6 primary care locations, the one that's actually in Bennington. And why do we do that? We did that because some physicians really request and ask to be in a larger group, and nurse practitioners and PAs working all together in a larger group. So we recognize that many of our locations are like other places in Vermont, 2 and 3 practice member practices. This will be larger. This actually can accommodate up to 12 individual physicians and advanced practice providers together. And there are advantages to that. There's the obvious advantages of covering for each other when someone's out, but also the call convenience and other efficiency gains. So we're looking forward to that. Again, we just finished it and we're recruiting into it. The next goes right along with that, and that is developing a truly standardized approach for bringing in advanced practice providers, transitioning them to independent practice out of their training. This was during COVID, it really got amplified that individuals going through training got less and less clinical experience. And they know that. They're asking for mentorship. They're asking for additional training once they get out of a formal program. So we are working on this, and it'll be very similar in all 6 sites so that we can open up our recruiting efforts to those who didn't have enough clinical experience to really be out on their own and have a large group of individuals who can mentor them, both physicians and experienced advanced practice providers. Like other places, bullet 3 there, moving to as many nurse visits as appropriate, so that frees up the physicians to see the more complex encounters, as well as having nurse visits do the Medicare annual wellness encounters. We're engaging primary care leadership. We always have, of course, this medical staff. It's one of the reasons that attracted me here is the collaboration among medical staff and with administration, but even more so to improve retention and figure out, when people do leave practice or leave our area, why are they doing that and what can we put in place? And that's not just more money or less hours. That's not what we're talking about. We're talking about what can we provide to them that helps them in their fulfillment and enjoyment of the practice of medicine. And it's been very enlightening, and we're moving forward with those things, and we will continue to do so. And then finally, we are working hard. We've been talking about it for many, many years, but now we are moving forward with a Dartmouth-Hitchcock Family Medicine residency. They are the sponsoring organization, and the site for most of the practice and the most of the time for the residents will be in Bennington. It'll be downtown in a new space, and they'll be at SVMC as well as other locations as needed. And that's a long-term strategy that's really going to help ensure that we have family medicine physicians here in this region and serving Vermont and southern New Hampshire for a long time. Now, specialty care access, we sat down and intentionally chose probably our 4 worst areas or close to it. Dermatology is a great example. I don't even know if you can measure how far out our next available appointment is, and that's because we have a dermatologist who's incredibly popular. She's also incredibly efficient. She doesn't do cosmetic dermatology, which is what a lot of folks coming on residency want, or they at least want a good percentage of their time to be focused in cosmetics. It's strictly medical, and that means she gets referrals from very far away. So if you do a good job, you get more patients, and the better you do, the more patients you get. And unfortunately, that means the access is limited. So we're working hard to try to recruit in either another dermatologist or an advanced practice provider. Having difficulty as many places, but I don't want to use that as an excuse. Just everyone to know it's on our radar. The same is true with oncology. I do know, and I think most people, we've talked about it for the past couple of years, oncologists want partners. They want people to be with them. It's harder to run a smaller center. However, we're expanding our footprint. It is now going to be a Dartmouth oncology center, and that's going to allow us to bring more people in, even people that are specialists and may want to work a day or two in Bennington and then a day or two or the rest of their time up at the Academic Medical Center in Lebanon. Cardiology, same thing, expanding our space. We just recruited in an interventional cardiologist. We don't have interventional cardiology here, but we see the need for it. It was reported on the Oliver Wyman, and we've been in discussions with DHMC. So at some point, we'll be coming back to you, hoping to do some interventional work here because we know our patients need it. And then finally, gastroenterology, ERCP, EUS, the things that patients often get transferred long distances for. I know UVM and DHMC get filled quickly with all the transfers. We continue to recruit in. We have a very highly productive gastroenterologist, but he can't get away to his procedures. So when you look at the sheets, which you will, you'll look and you'll see, oh, he's not that productive. Well, he's very productive. It's just that he has to see a lot of outpatients. Those don't generate the RVUs that are typical in a large academic or larger center where the physicians are mostly doing procedures that generate higher RVUs. So that's just a very quick, brief overview of the efforts we're doing on access. And of course, we can talk more about that at the end.
And again, you're going to hear it throughout this presentation is the strategy of working with Dartmouth Health. A long time when I came here over 16 years ago. When my first year here, I spoke to our board and medical staff very upfront and said, you know, we've done well over the years, but it's not going to be sustainable in the future. We need a partner that is able to bring both the intellectual assets and capability as well as the, a financial base to work with us. And we're trying now to integrate where we can. It's going to be an aggressive strategy over the next few years, looking a lot of it looking at administrative overhead costs. And you see some services right here that all of them have a plan for integrating with Dartmouth. And if we can help to do, if we can forge those relationships, and we will, it will help to share cost. And I think we're making strides in each of these areas here. As I look at the whole C-suite of our institution, the goal is to downsize the C-suite, have less administrators, and the ones that are here wear dual hats. And you'll see from even the introductions, you have Bob Laba, who is now our Vice President of Administration, took over the human resource function. Our HR VP retired, and Bob's taken on both the HR as well as finance. And Trey's doing the same with in terms of clinical services, as well as being a chief medical officer, and Pam Duchesne who's our chief nursing officer now took over the role of our VP of quality. So all these functions now we're trying to integrate, and it's much easier and much more effective when we have the support of Dartmouth Hitchcock to help us in areas where maybe our executives and managers and leaders may not have as much of the background, but with the support of the system, we can make it work, and we are making it work. So that's a key strategy of over time to reduce the costs of care, affordability, and administrative overhead costs. Next slide. And this, again, this talks about our benefits over the next 2 to 5 years of what we're looking to do, and probably the biggest item on that list right now is the move towards the Epic platform, which is essential for our integration and consolidation. We're on a different system, the Meditech system, and Athena, which is not serving the needs of integration. So this is it's a long-term project. Won't be installed. It won't be a conversion until 2028, because that's the amount of time it takes to lead up to this conversion. But it certainly is very, very critical, and it drives so many of these other initiatives on this page and other pages. And so we're excited about that, and we're keeping our eye on the ball as we move ahead and create that model. And then just I want to mention quickly about our direction and how it relates to the Oliver Wyman recommendations. And I would say that all these things you see listed here, all recommended by Oliver Wyman in their report, and ones which we are all over. And we are trying to move as quickly as we can to make this happen. These are both clinical initiatives as well as administrative initiatives. Clearly, as you see the Epic there, but we're growing new services as Trey just outlined, from interventional pain to vascular to robotic surgery, and we made a major statement with moving into the mental health service realm. All things that are strong community need, all recommended by the Oliver Wyman study, and one which we are taking to heart and we're work hard on. And certainly the primary care is a big piece that Trey talked about. And we could never be able to do a residency program without Dartmouth Health stepping up and say, we will be the sponsor of that program. That's another example of the key aspect of the need here. And the same, I'd say, on mental health services. Their team stepped up and say, we will provide medical oversight and administrative oversight to open up a new inpatient unit for the state of Vermont, which will be a statewide service for adolescent inpatient services. So again, I'm not going to go through all these, but I want to give you a sense of that we are taking the Oliver Wyman recommendations to heart, and we're creating initiatives throughout our organization and with Dartmouth to make those happen. And hopefully we can make them happen as quickly as possible, with the eye towards access, community need, and affordability. Next slide.
Great, thanks. Now I'm going to go over some of the key summary, as well as meeting the guidance that was set for us. So as Tom mentioned, the 2026 budget has been an extremely challenging process. There's been many internal and external factors and pressures impacting SVMC. Now, throughout this process, we have kept 5 guiding principles in mind to ensure that all of our decisions are all patient-centric. First, SVMC understands that the pressures facing Vermont healthcare and the system. Our top principle was to stay within the budget guidelines that were set for us by the Green Mountain Care Board. Second, Vermont has an access problem, especially in southern Vermont, as well as especially in primary care. SVMC is working to increase that appropriate access. Healthcare transformation is imperative. SVMC embraces transformation, and is why our Oliver Wyman recommendations are on the forefront of our SVMC budget assumptions. SVMC also believes that higher quality will lead to lower cost. And finally, all of this, as Tom was just mentioning, all of this would be extremely difficult without the support of Dartmouth Health. 2026 is another year where we take steps to further our membership in the system. So in addition to Act H266, there's two major assumptions in our budget with multi-million-dollar impacts to SVMC. The first is the 340B drug pricing program. So just to remind everybody, the 340B program enables covered entities to stretch scarce federal resources as far as possible. So SVMC uses the savings that we get on drug purchases in alignment with these intended purpose. So the savings for SVMC are about $8 to $10 million annually. This helps SVMC as a small rural facility serve a quite large indigent population. We're on pace in 2025 to write off about $3.2 million in free and reduced care based on our financial assistance policy that we have. Looking forward to 2026, we've increased that expectation by an additional $1.5 million. Looking at where we've been over the last couple of years, that is about almost $3 million more than where we've been 3 years ago. In addition to our financial assistance policy, 340B savings help us keep critical service lines in the community that typically don't cover their cost. OB services, alcohol detox, and even just running a hospital 24/7 with a payer mix that's a majority of Medicare, Medicaid is a challenge. It's a complex formula to be eligible for the 340B. I'm not going to go into the details and all the specifics, but we are anticipating to be not eligible after our fiscal year 2025 cost report is filed. And that's for two main reasons. One, the number of Medicaid patients that SVMC services on an inpatient basis has decreased slightly. But the more material aspect that's kicking us out of the program is our SSI percentage has significantly dropped. The latest published stats are from 2022 and the 2023 time period. And this dropped about 1.23% over the previous published stats. With the loss of the 340B program, it takes out $4.5 million of savings from the organization. So SVMC needs to transform to mitigate these savings. How we're going to do this? So in this budget, we have implemented several different factors. The most material ones are listed on this page, and I'll go through them. Management restructure of $1.5 million. So we have a plan to restructure our management structure, and our plan is being currently rolled out. Our occupational health and employee health is being restructured to be more efficient and combined with other services. Finally, we have clinical contracts and supports that are being modified to right size with the needs of the community. Looking at services that are going to be impacted. First is closing of our Mountain Medical part-time walk-in clinic at the Mount Snow ski resort. This sees about 700 patients annually, and about 85% of those patients are out-of-state visitors. We are working to see if there's an alternative way that we're going to be able to provide this service without completely closing, but at this time, we're still working through that. Our plastic surgery service line is a very low volume. And finally, we're pausing our pulmonary rehab program. This again is a low volume, and we are looking to provide the services in a different, more efficient way. But we are calling this a pause because we will be looking to re-roll out this program as part of a comprehensive cardiovascular strategy. The second major assumption is around our radiologists and the radiology practice. So we've worked with the Green Mountain Care Board staff to identify this practice as being excluded from our budget guidance. This is not new revenue or expense to the Vermont healthcare system. This is shifting acquisition of a private practice from an unregulated entity over to a hospital regulated entity. We're not expecting any change to the patients for this change in service. I'm just going to pass it over to Trey quickly to talk about clinical reasons for this change.
Yeah, so if you can go, I think there's another slide, or if there's not, it doesn't matter, Bob. The point here is that radiologists, like lots of other physicians, when they're in small groups, they can't cover their overnight call. They can't cover a lot of weekend call because there's just not enough of them, and they're already working 60 hours a week. So what ends up happening is, which you probably are all familiar with, is we send images out to be read by a very expensive third party, and we don't want to do that. So therefore, but they can't recruit in because they can't cover those nights. So by joining a much larger practice, the entire system of Dartmouth Health, once we get aligned with our EMR, we will be able to read overnight studies as a part of a system and not send these things out to these very expensive third parties. So that's one aspect, and that makes sense, right? They can join a group of 40 doctors so that all the nights are covered and weekends, and we can get through the material. But the other part is procedures, and many people don't realize this, but radiologists do a lot of procedures in many places. And at SVMC, we've been able to keep people from being transferred for things like liver biopsies, lung biopsies, by doing them here rather than in tertiary care centers. There's no reason that the radiologists here can't do it. But when they're tied up doing those procedures, which can take 45 minutes to an hour, all of those imaging studies get backed up and we have to send them out. Again, very expensive rather than having our radiologists read it. So it's a give or take. Either they don't do the procedures and we send the patients out, or they do the procedures and we send the images out. And so by having them join the practice, we hope to be able to recruit in and fill those gaps. And actually, we already have, because as soon as they announced they were joining, we recruited in a 5th radiologist. So it's already paid off. We've reduced the amount of images we've had to send out to a third party and increased the number of procedures that can be done here.
So with those major assumptions and all of the other budget assumptions that we have, we are projecting a small operating loss for fiscal 2026, slightly better than where we're projecting to go in 2025. And at the same time, factoring in the impacts of the reduction in revenue from H.266, as well as the increase of expense for 340B. I'm just going to quickly walk through the spreadsheet. There's a lot of numbers on this. So the first two columns are to the left, our fiscal 25 budget, as well as the projection. The middle column, the third column, is our original budget that was submitted to the Green Mountain Care Board on July 1st. So as SVMC is going through the budget process, there's many steps to get it to the point of submission. We developed the budget with all of our management as well as our medical staff, including mitigating the $4.5 million cut to 340B. Prepared a presentation to the board as well as DH leadership, and then H.266 was passed. So we did not have enough time to digest the impact and strategically plan on how we were going to manage for a $6.6 million reduction in revenue. We've taken the time to do that. And the fourth column represents the offsets that we are requesting in order to mitigate the impact of H.266 for SVMC, given the circumstances with 340B. Finally, the fifth column is our final budget that was resubmitted to the Green Mountain Care Board last week. Risks and opportunities. As with any budget, volume projections are always a risk. To mitigate this risk this year, SVMC was relatively conservative on any volume projection. As we'll see a little later on, most volume projections are staying pretty flat. Inflation is a risk as well as the federal government budget reductions. And what this means still remains unclear. On the opportunity side, we still have the 340B program listed as an opportunity. Because it's not in the budget, if we're able to see additional patients and be able to qualify for the 340B program, that would be an opportunity. But at this time, we're not expecting that to happen. Finally, being able to repatriate care back to SVMC out of higher cost areas would be an opportunity, as well as looking at our revenue cycle processes. Taking a minute to look at our, to take a look at where our budget stands with the benchmarks. So SVMC broke our budget up for revenue and expense down into 4 buckets. First is business as usual, implementing the 340B changes and solutions for the added expense. Next was the hospital transformation with the recommendations for Oliver Wyman in the pass of Act 167 and impact of reimbursement reduction of H266, as well as accounting for the radiologist. So the benchmark set for 3.5%. SVMC's budget as presented is 1.9% growth over last year. So starting with the approved budget, we have our business as usual services with a 2.5% increase of net patient service revenue. This is included in the number. Included in this number is a 3.8% charge master increase, which is applicable to most services, excluding our professional fees for areas like primary care, drugs, and supplies. We then brought in the Act 167 Oliver Wyman recommendations. First one is looking at primary care. We are, as Trey mentioned, on slide 15, we're additional primary care providers that is bringing in an additional just under $423,000 worth of revenue. Second recommendation, looking at increasing cardiology, including cath lab capability. Our expand cardiology initiative in the budget is included there, an additional 0.7% change in revenue. The intent of both the added cardiologists as well as our cardiac CT is to keep patients local and out of the higher cost places of care. Finally, expanding specialty services. Again, all the items that Trey mentioned on slide 16. Our focus is in 2026 is expanding our vascular services. So in addition to the 2.5% increase in our business as usual budget, the additional services adds up to 1% net patient revenue. So even with that, we remain in compliance at the 3.5%. Taking into account the impact of H266 and the $6.6 million reduction in revenue, which is equal to 3.1% of the change in net patient revenue, that drops our unadjusted patient revenue to 0.4% over last year. Looking at how we were going to be able to mitigate this with financial impact and maintain critical services to SVMC, we are proposing to add a 3% price increase across the board and a 20% increase to our room and board charges. That brings the total net revenue to 1.9% increase over last year's budget, which is still significantly below the guidance. Finally, just wanted to include the radiologist to tie out to the financials. Looking at the commercial rate increase, budget established was 3%. Our overall impact to the commercial payers is about 0%, a small increase of $33,000. Majority of this rate increase impacts other insurances other than Blue Cross Blue Shield Vermont. In our geographical location, many of our commercial payers have New York and Massachusetts Blue Cross insurance. Based out on this data, Blue Cross Vermont will be paying SVMC less for services than they did in fiscal 2025. This varies by payer ranges from -2% up to 3%. So we are within the benchmark established. Looking at growth in operating expenses, once again, we're within the benchmark, 2.3% compared to 3%. Similar to revenue, we're focusing on 4 buckets. Business as usual, adjusted for 340B, is a 1% increase over fiscal year 2025. When we add the same Oliver Wyman recommendations as we did for net patient revenue, this adds 1.8% or $4 million worth of expense. That gets us to our total operating expense of 2.8%, which is below the budget guidance. As we revise the budget In response to H.266, we, in addition to looking at revenue, we also looked at expenses one last time and what we could change. What we did here was we reduced expenses by about $903,000. This was made up of two main buckets. The first, the smaller bucket, was a renegotiated contracts, which changed the service, some of the services and the amount that we pay for those services. The second bucket was reducing the total compensation for the executive team. Final budget percentage is 2.3% over our fiscal 2025 budget. Once again, within guidance, and same as revenue, we added the radiologist expense so that we could tie this into the financials. What is SVMC doing to limit commercial rate growth? First, we are reducing our total administrative expenses. This is a decrease from 18.1% in our fiscal 2024 budget, reduced to 15.2% in our proposed 2026 budget, excuse me. These numbers vary a little differently from our cost report, which has been mentioned in the past because of our salaries for our providers are not included in our salaries because of our arrangement with the Dartmouth-Hitchcock providers. When you factor in that $40 million worth of expense, we come up with percentages similar to these. What we do to monitor whether our admin costs are benchmarked or not, we use the benchmarks from our Premier system. This is a productivity system that we implemented in 2025, which monitors all of our salary expense for all clinical and non-clinical departments to specific targets for each. So that is how we are benchmarking our costs. Second is SVMC is eliminating all marketing that hasn't been previously committed. So we are significantly reducing our marketing budget to the bare minimum, only what we need to keep the community up to date about our critical service changes. This provides that they can, make sure that they stay in Bennington for their care and don't seek care elsewhere. As it's also noted, SVMC does not have a paid lobbyist, and really these costs can be classified as community communication rather than marketing, the costs that are remaining, the $85,000. Next, I want to talk about executive compensation. So SVMC has a review policy that includes our local governance structure in order to review and approve executive compensation. Part of that policy is to target the 50th to 55th percentile of our regional market based on an outside third-party review. It's also important to note that this percentile target is the total compensation that includes base pay, variable compensation, and benefits. As with many large organizations, SVMC has a variable component to executive compensation package. This ensures the goals of the organization set by the board are being met. These goals are also further the goals of Vermont through Act 68. SVMC's current organizational goals include access for both primary care as well as specialty care, patient safety, quality, patient experience using our Press-Ganey survey results, workforce, looking at what our employees are saying about SVMC through our engagement surveys, as well as our voluntary turnover rate and how we're able to maintain a good staff retention program. Finally, financial sustainability is the circuit breaker of the entire program, with operating margin goals being set, as well as philanthropic goals. Executive compensation, we believe, follows the principles of Act 68 for access, quality, affordability. Important to note, in our fiscal 25 projection, there is no variable compensation. The same for the 2026 budget that has been eliminated from the 2026 budget. So we're looking. Oh.
And just to add to that, this kind of goes back to my earlier comment, is that how we're structuring our C-suite in terms of roles and responsibilities and numbers of people. The idea is to downsize. The idea is to have shared responsibilities of different divisional accountabilities, such as I said earlier about for Bob taking on both finance and human resources, and then utilize wherever we can the Dartmouth Health team, their corporate services to help support our management throughout the organization.
Finally, looking at executive comp, want to call out the comparison of our executive and clinical leadership to the staff that provide direct patient care. So our average for our executive team is about 9.5 times. The CEO's salary in the budget is set at 15 times, CFO at 10, and all others are less than 10. Next, what SVMC is doing to limit growth is making investments in the clinical workforce. Now, through the pandemic and SVMC has very few travelers, especially in nursing. No inpatient nursing travelers at the time. This has been done. This has been accomplished through many programs that we've already talked about: the magnet designation, the pipeline, but also our nursing leadership provides direct patient care, and they fill in the needs and wearing scrubs every day and fill in the needs where they are. I feel that it's a strong program and that we're able to retain staff in order to not have the traveler expense. Trey, we'll kick it to you on expanding access of care.
Yeah, just be real quick here. Thanks, Bob. Just because we've been talking about expanding access, but these just happen to be some other areas where we've devoted a lot of time and resources. One is to have a true place in our emergency department that is separate from the rest of the ED, so that we can take care of patients who are in mental health crisis in a protected area, keep them away from other patients. And when I say that, it's not only for the other patients, but it's for them, so they can have a more healing environment. And we've gotten a lot of positive feedback from those patients, and we'll continue to work with them. Next is that, rather than trying to do things piecemeal, we have a very strong relationship with our designated agency next door, United Counseling Services, and continue to have a great partnership for having additional services for those patients that have mental health needs. We've expanded and formalized our alcohol detoxification program. These are patients that are seeking usually inpatient rehab, sometimes outpatient rehab, but they need a few days in a hospital setting to ensure their safety as they go through the withdrawal that can happen from alcohol. We have a formalized program now where those patients can have that done here at SVMC before they go on to their next stage in recovery. We also now do inpatient dialysis for our 45 or so patients in the area that are on hemodialysis. This is excellent in that it prevents people from being transferred, unless, of course, they do need a tertiary care center. Basically, the way we handle it is, if the patient is on dialysis and they would normally be admitted to a community hospital if they weren't on dialysis, then we admit them to us. And that's been very successful. Started that a few months ago and already have had probably a dozen patients come through. And then finally, a lot of our patients have been traveling to the Albany area for all of their vascular service needs, because we haven't had vascular surgery here or vascular intervention. And now we do, through collaboration with the medical center, with Dartmouth Hitchcock Medical Center. So 2 of the vascular surgeons make the trip twice a month. It's looking now to move to 4 times a month, where they see patients in the office, perform imaging studies, and also take patients to the operating room for sort of more minor type vascular procedures that don't need a tertiary care center.
Again, not going to dwell on this too much. We've talked a lot about what we're doing with Dartmouth Health, just continuing shifting administrative functions, but also expanding our group purchasing opportunities. So one area that we are expanding into now is the surgical robotic surgery. So through our partnership, through our membership with Dartmouth Health, being able to bring a surgical robot for surgical purposes into SVMC at the lowest risk possible, financial risk possible, which is really good for SVMC and really good for Vermonters. This slide was in last year's presentation. I just wanted to share because it's still relevant. SVMC is at a right price with peers and in range with costs. We're continually looking, reducing costs, and remain a great value, a great option for Vermonters to get healthcare. Just to quickly hit the highlights of our top level stats, marginal increases on our inpatient volume, expecting to remain relatively the same as 2025 budget. On the outpatient side, again, remaining relatively consistent across the board. The one area that's increasing is our surgical cases and endo cases, and this is mainly related to additional bariatric patients, mainly from New York, helping to offset the cost. Days cash on hand. The growth in days cash on hand is mainly due to market performance. We do have, so as we see here, the 184 days as our budgeted total days cash on hand. We do have an operating line of credit that does need to be paid off. We are paying interest on this. Majority of this is related to COVID era borrowing, but also includes some operational expenses through 2023. So backing that off, it reduces our true adjusted days cash on hand to about 150. We also have many items, strategic projects that we need to do. We've earnestly and responsibly been saving money to making these investments. The first is our master facility plan. As Tom mentioned, we have one of the oldest facilities. We have chiller, roof, elevator, you name it, infrastructure needs. The estimate for those costs are about $50 million, which equates to about 76 days cash on hand. Our cancer center project, which we have an approved CON for, is 21 million. Looking at our upgrade to Epic, as well as all the infrastructure needs, 35 million. And finally, looking at our annual routine capital, 7 million. So bottom line is SVMC has a lot of deferred maintenance that we need to do in order to provide the high level of quality care. Looking at our routine capital for this year, our major focus remains on the Epic transition because this unlocks so much for SVMC. There's very small amount on non-IT projects, which is, in my opinion, not enough. But we will be continuing planning in order to be able to afford what we need to. Finally, just a quick look at our CON projects that we have underway. We have 2 major CON projects ongoing and expect to file a third CON this upcoming fiscal year. The adolescent inpatient psych unit, we're working with the state of Vermont as well as other partners, which was approved in March 2025, as well as the expansion of our cancer center, which was approved in July of 2025. The CON that we're expecting to file in 2026 is the Epic electronic health record replacement. That is the presentation. I'll ask Tom if he wants to make any closing remarks.
Well, Trey, do you have any remarks you want to make?
No, I'm good. I'll wait for the questions. Thanks, Tom.
Okay. All right. Well, listen, I just want to, again, as Chair Foster said, I'll be stepping aside this year. And I appreciate all the support that this board has given myself and the system. But I will promise you that SVMC's commitment to the community, the state of Vermont, and health transformation will remain steadfast. I know the individual who will be in this role will be right on line with that. And I want to, again, personally thank you all. These are difficult times, but I'm convinced of us working together, we will find a path forward. And as a hospital and as a member of a larger system, we can improve and do better, and that is our goal, is to do better. And from our board, our leadership team, our providers, and our entire workforce, we're committed to strengthening our healthcare system and to increase the value of care that we provide to our community. And I thank you again for the role you play, and we look forward to answering your questions. Thank you.
Thank you very much, all. And I really appreciate, Mr. Green, your attending on behalf of the board. And Mr. D, thanks for all your humility and partnership and work together with the board. You've ingrained a really positive culture in your organization, and you should be commended for the career you've had there. So thank you.
Thank you.
That doesn't mean we're going to let you off the hook easy, though. So I'll start with board questions. I'll turn to member Merman.
All right, thank you. Yes, similar remarks, Mr. D. This is only my third year, but I really appreciate your approach to budgeting and approach to this process. I do think that when I think about the traveler crisis of COVID, and I think about Southwestern, Vermont Medical Center and what you were able to accomplish there with retaining staff, I think that culture comes from the top, I think, and we will miss you. So, okay. On to the tricky stuff, though. Let's see here. Okay. So this one actually first one goes to you, Mr. D. Again, this speaks to your enthusiastic endorsement of the affiliation with Dartmouth Health and the belief that this is going to improve cost containment and access and the services for Southwestern Vermont Medical Center and for Vermont. And I this is more of a comment than a question, but I do, it's totally a comment and not a question. But I do think you're up against some rough data that, generally speaking, across the nation, when we have consolidation, we see, increased costs, decreased access, and flat quality. And frankly, you pretty much would have a hard time improving quality. So I think you're going to have a hard time showing quality benefit. So I wish you best of luck in this venture. I hope it works in the way that you believe it to work, because you'd be bucking a trend on a national level by that. But all right, so off to the questions. So this one's sort of a rapid fire from your presentation, Dr. Dobson. Just a quick one on the radiology thing. So are you doing all your reads in-house now? You're not sending any out?
We are sending some out, Dave, but not as much. I could give that, those numbers to you. The fifth radiologist just started, maybe June. So I don't have a lot of time there. We are also doing more procedures now that they've started, in this process. And the reason is because you'll understand this, they wouldn't get much as a private group for those professional services for doing the procedures, and it just made so much more sense to continue, the reads. And what ended up happening is patients were having to travel to get their just, almost routine imaging biopsies. So that's improved significantly as well.
Okay. And then when you send reads out, do they go to Dartmouth or do they go to whatever, VRADs or something?
Well, they go to VRAD, and so that's a big benefit of having the groups, join in our system, because now they can go to DHMC, except they don't today because we don't have the PACS integration, which will come. When we say Epic integration, but it's way more than Epic. It's all these other types of software initiatives, and PACS is one of them. We're exploring a way to try to get that done sooner rather than later, but still running into some roadblocks. But hopefully sooner. And the way it works in that system is just that there's a group that reads at night, and our group will participate in that, but it'll be very few nights per year because the size of the group is so large.
Staying on Epic, $35 million for Epic implementation, is that going to be paid for by SVMC or by Dartmouth?
So, well, SVMC will pay about 25% of it, similar to what Mount Scottney reported, for the costs of the Epic itself. The rest of the whole IT thing will be a little different. Maybe I can let Bob talk to that.
I guess the question is the 35 million SVMC's share of the implementation.
That's the total cost of the implementation, as well as the infrastructure upgrade needed in order to be able to plug into Dartmouth's Epic system.
Okay, so you won't have that day's cash on hand hit of full 35.
Not
Correct.
potentially correct.
Okay. One other from your presentation, you were talking about increased charges, but excluding primary care. Why not increasing charges for primary care?
We did not increase any charges to any of our professional services. We
Okay.
want to encourage people to use primary care and stay out of the ER. So we felt that changing the cost for those primary care visits was not appropriate.
Yeah, just from my perspective on this is interesting, maybe because I think that when often people will say, well, primary care is not sustainable and it's not generating enough revenue, so we need to, that may be something that could be, people sometimes think of cutting because it doesn't have the revenue generation. But if you don't allocate charges in the area where, if you don't allocate rate to that area, then it won't be sustainable. So as long as it's acknowledged that by improving affordability, you're kind of potentially risking its sustainability, that nuance is understood. I can appreciate that. So.
Our strategy is to expand primary care at the same time as we're not increasing charges.
And then on the executive compensation slide you put up, what percentage of that executive compensation variable comp is related to the operating margin goals?
I can get that for you. I don't have that rate, the breakout of the per goal, but because we do not have anything in the budget for variable comp for 2026, so or 2025. So it would all be a historical look back.
That's probably not relevant to the 26 budget then. So thank you.
Yeah, I was going to say, just from the board level, Dr. Merman, we've eliminated that for next year. So
thanks. On slide 46, Mr. Laba, can you re-explain this to me? The budget that I read has a 3.1% charge master increase, and I didn't see any mention of a 20% room and board increase, and then this slide has a 6.8% charge master increase. So I'm trying to figure out what is the submitted request.
Last week, we submitted a revised request, which included an additional 3% increase. So the original request was 3.8% up to it. So that is where the 6.8 comes. So again, that's across the board except for professional fees, drugs, and supplies. The additional request in the revised budget submitted last week includes a 20% increase in room and board rates.
Okay. And the revised budget increase was to offset the Act 55 H266 drug pricing.
To maintain services based on the reduction in revenue in that act, yes.
Okay. And do you know what the commercial rate is then for that charge master increase of 6.8%?
Can you rephrase the question?
So in the guidance, it discusses a commercial rate, which is the effectuated charge master increase. So
yeah, so on that slide, it says it's just under $6 million is what the commercial rate increase based on a 6.8% charge master increase would be.
And do you know what percentage that works? Sorry, interrupt.
I'd have to look at the total commercial payments to get an accurate number.
That would be helpful. I'm sure our hospital finance team can calculate it too, but okay. And since we're chatting, there's something that's that was brought up in the legislative session this year that's not in the budget submission, but relates to your budget, which is Medicare reimbursements that you've been working, my understanding is you've been working on an analysis that Voz had presented with a slide that shows that claims that Vermont is getting pretty significantly less per diagnosis Medicare reimbursements. And I wanted to ask you some questions about that. Would that be all right?
Yeah, I'll do my best to answer. Yeah, absolutely.
All right. So my understanding is that SVMC hired a consulting company or an outside firm to do this analysis, or did you do it yourself?
We did not. We did it ourselves with claims data that we have access to through the Dartmouth Health System.
Okay. And do you know if that claims data included the critical access hospitals in Vermont?
I would have to go back and look.
Okay. I guess the questions that I would have is, if we know that critical access hospitals typically get paid fairly high Medicare reimbursements, and so if that's including them, then it's, we're blending the high Medicare reimbursements with the low Medicare reimbursements. And do you know if that claims data included claims that were paid by OneCare?
Yes, they were based on as if OneCare was paying us for a fee as a fee for service.
Okay, and was that just Southwest? Is that just SVMC, or is that sorry, not Southwestern? I keep saying Southwestern, Southern. Is that just SVMC, or is that all?
All.
Okay. And so, and are you was this per DRG for the inpatient, or did you group a bunch of DRGs together?
We can look at it grouped or separated.
Okay.
And critical access were not included, just to follow up on that question.
Okay. And did you do any case mix adjustment, or do you know if this data takes into account the risk complexity of the patients that are in these, and the claims that are in here?
I do not believe it was case mix adjusted. I believe it was pure payments.
Yeah, I think it was all claims, Bob, wasn't it?
Yeah.
And this is just DH data, or this is all Medicare?
No, this is data that's purchased by DH that they have access to.
Okay.
The advisory board.
Would it be possible for our staff to be able to evaluate that claims data set so that we can better understand these findings?
I don't see why not.
That would be super helpful.
Absolutely. I wasn't the lead person doing the analysis, so I will connect with them and yeah, absolutely.
All right. There was a mention in your submission that you're working on revenue cycle improvements. Do you expect these revenue cycle improvements to increase your revenue from payers, commercial, Medicare, Medicaid?
We are expecting our denials, especially around the Medicare Advantage plans, is where our focus is, based on making sure that we have the proper prior authorization, as well as any documentation that's needed so that we can reduce the denial of payment for the services that we provide.
So I have some more questions about the charge master increase, but I think now I understand what you're asking for. When you approach commercial insurers regarding increases, do you ask for across the board increases, or do you ask for certain areas where you increase higher rates and certain areas where there's lower rate increases?
Our commercial contracts don't quite work that way. So we typically receive the rate based on our rate increases across the board. There's little opportunity based on the way our contracts are structured to focus outside of how we do it with the professional fees versus all other facility charges. So that's how we focus it.
Just discussing some of your expenses. So it sounds like you've had this pretty significant increase in projected bad debt. Could you explain that a little bit further?
We're just being, we want to make sure that we're conservative with our bad debt assumptions, especially with the affordability crisis in Vermont. So we're making sure that both bad debt as well as our charity care financial assistance amount is adequate enough to of what our expectations are for 2026.
Okay, and I guess that sort of goes to a 340B question then. So if it sounds like you're unfortunately probably not going to be able to qualify for 340B, which is a significant amount of revenue or savings, depending on how you define it, it'll change the operating profitability of the organization, I suppose. So if you do end up qualifying for 340B, is there a plan to, how would you mitigate that with regards to commercial affordability for Vermonters?
Absolutely. I think if we are able to retain 340B designation and are able to achieve the additional $4.5 million worth of savings, that there would be, we would look to revise our budget.
Okay, when do you think you'll find out about that 340B designation?
We will know the end of February when we file our cost report.
Okay, so if you did qualify for 340B, would we expect you to come in for a mid-year rate adjustment, or would you, how would you approach that?
We're right. We would relook at our budget with the additional $4.5 million coming in and be able to adjust our rate.
Okay, thank you. I reviewed the Schedule A for the provider acquisition, and it just looked a little strange to me because the expense of this practice and the revenue of the practice exactly matched. Can you explain to me what's going on there?
Right. So the expense of the practice, we're not anticipating on making a profit on bringing on the additional providers. We're anticipating that our professional fees that we collect for the services that the radiologists perform equal their salaries. Our assumption that professional line of business is break even. And SVMC is already billing for the facility fee for the X-ray for the different radiology procedures, and because we're that volume's not changing.
Okay.
So that on Schedule A is only the professional side, only the radiologist salary as well as the professional fees that SVMC will receive for the radiologist billing.
Just make sure I have any more questions. I think that's all I have prepared, so thank you. So
Thank you.
just one more thing I want to say is I would like to congratulate you on your Sloan Institute ranking for equity. Strong work. Thank you.
I had a couple on the provider transfer Schedule A. I actually had a hard time following it too, so I appreciate a little bit further explanation. On Schedule A, it says gross patient care revenue prior fiscal year was $2.5 million. Is that the prior year to when SVMC acquired the practice?
Yes.
And then current fiscal year projection, so that's fiscal year 25, and that includes pre-acquisition and post-acquisition?
Let me pull up the schedule and validate that. I don't want to say the wrong thing.
Okay.
While he's doing that, for clarity, they and I think it's probably pretty obvious, Owen, but they started in July. I think July 7th is when they became that.
Right. Yep, exactly. So, and then it says current fiscal year projection. So just trying to get, is that the entirety?
Yes, the entirety of 2025.
Right, through
Yes.
whenever you submitted this. Okay. That seems like a huge jump from 2.5 million to 10 million. And the 10 million is only partial year. Why is it such a big increase?
I'm having trouble locating the file. Can I respond
Yeah.
to that as a written question?
Sure, yeah. So the question is, what causes a huge jump? It's only, you still got a quarter to go or part of a quarter to go since you submitted this, and it seems, 4 or 5x increase over the prior year, which is really significant.
Yeah, I'll do a deep dive on that schedule and respond to the
Okay.
board.
And then related to that, I think in the written submission, page 4, it discusses this acquisition and it says, quote, moving the physicians under the SVMC umbrella does not increase the cost of the services. It shifts from an unregulated entity to a regulated entity, close quote. I didn't quite follow what that meant. When you say it does not increase the cost of the services, what are you referring to?
We're not raising the cost of what Vermonters pay for those professional services.
Right, okay. So the price that
So it's
Vermonters
shifting
paid,
new revenue to SVMC, but it's not new revenue. It's not new expense to the Vermont healthcare system.
it's price neutral from when you did not have the practice to when you do.
For Vermonters, yes.
Right, okay. Great. I wanted to,
Can I just follow up, actually back on your follow-up 1
Please.
second?
yeah, go ahead.
So I guess I'm a bit confused on that because I thought part of the reason to pull the practice into SVMC was because the reimbursement for procedures was low. And so I would assume then the reimbursement for procedures is going up to do IR procedures. You're holding the professional fees the same as when they were as independent practice.
The risk for a private practice physician goes away when the hospitals, and when they're on salary for the hospital. So there is, right. We are not anticipating the fee to go up for procedures or reads of imaging studies.
Okay. Thank you.
Question on losing 340B status. This is perhaps a little granular, but I was having a hard time understanding what was causing you. I mean, I understand it's SSI and it's your percentage of Medicaid patients, but I think of Bennington as a fairly impoverished area relative to the rest of the state, and I was surprised to see that. Do you have any further explanation of what's going on? You would be one of the last hospitals I would think that would happen to.
Right, so we've been on the cusp for the last 3 years, hovering around the 8% criteria. In 2024, when we filed our 2023, when we filed our cost report, we were exactly at 8.0%. Last year, because our SSI percentage jumped up, we were at about 8.3, 8.4%. Now we're dropped significant because of our SSI percentage predominantly. We've dropped below 7% year to date. We're taking, obviously have been doing a lot of work on determining why this is. So our Medicaid population, our Medicaid utilization hasn't dropped as significantly as the SSI percentage. So we're digging in to see that supplemental security income, why that percentage has dropped. We don't have a definitive answer today.
It just seems like a wild swing, and it's hard for me to understand what would cause that.
We were just as shocked when
Yeah.
the just came out.
Do you have any working theories as you've looked at it so far?
Looking at who qualifies for SSI and what federal staff, where they're working. Don't believe there's anybody in Bennington County. The nearest SSI office is in Rutland, I believe. So that could have an impact to who in Bennington actually qualifies for SSI benefits. That's our working theory, but we're working to validate that.
Okay.
You
On
know,
the,
also there was a, Chair Foster, over the last year and a half, North Adams Hospital reopened. Very, a fair amount of Medicaid services over there. Patients were coming to our hospital. So they have pretty much migrated back to that region. So I think it's, it's had some impact in terms of our Medicaid volume coming to us.
okay. On 266, the drug price cap, you're part of a network and your other hospitals aren't subject that I know of to that, or maybe Ascutney is, but some of the others are not subject to the cap. Has there been any discussions about trying to move or encourage the patients to go to other network hospitals without a cap?
We have not had discussions to move patients to other hospitals to avoid paying the cap.
I'll just put in a marker that
It's been just the opposite, to tell you the truth. I mean, it's a lot of discussions about how other areas can decompress and send business to us. So
great. Thank you. I'll just put in, a marker that if that is something that comes up as a plan, please provide notification to the board, because I think it was a significant effort by the legislature, as you all know, to do this intentionally to drive down costs, and efforts by hospitals to circumvent that would be counterproductive to some of the state's goals. So I appreciate that that is not something on your radar and you providing disclosure if something changes on that front. Couple questions on the network, and I appreciate the comments about how you're thinking about the network and how to try to ensure that you actually gain the efficiencies that drove the affiliation. Do you have any benchmarks or goals or any sort of timelines on what you're holding yourselves accountable to in terms of achieving those efficiencies?
well, certainly in terms of the administrative side, the backroom functions are moving as we speak. Is there a total number we can point to? To tell you the truth, Chair Foster, we're trying to make an organizational move towards becoming, surviving on Medicare. That's not an easy thing for us, but I think we're trying hard to do that. And so we're working on, a strategic plan in terms of what services, both clinical and administrative, we can start to, integrate together in timelines. So we're really focusing on really a 2 to 4 year period of time, as I said in my overview. So it's pretty aggressive, but the driving point is our IT conversion, because we're not able to take advantage of a lot of initiatives until the IT platform is in with the Dartmouth system.
Do you have a sort of roadmap of different buckets of where some of the efficiencies may come from and potential savings due to them? So, for example, consolidation of back office services, a goal is X, a stretch goal is Y, timelines this, IT integration, financial savings is X, that kind of thing.
We could show you some of the strategies that we're looking at in terms of savings and when they would take place. Certainly one that we focus on all the time is a whole shared service side, shared purchasing. Pretty big initiative, and that certainly is I think an opportunity that we think is certainly over $1 million, but there's other areas too that I think we can outline for you in detail.
I think that'd be beneficial. I think just having goals and accountability to them would kind of begin addressing some of what Dr. Merman talked about, that as these things have happened across the country, it hasn't always pulled through. And I know that you guys are working very hard to not follow that path, and I appreciate that. So thank you. On the parent company financials, I don't know. Did you provide an org chart for where you sit in the Dartmouth system?
I don't,
I didn't see one.
probably not, but we can certainly, that's very easy to give you.
Okay, yeah. It'd help me understand because I know you also have SVMC has a parent entity. What's that called?
That's Southwestern Vermont Healthcare is the parent of SVMC, and Southwestern Vermont Healthcare, which is SVHC, comes under the parent of Dartmouth Health.
So it's a sole, Chairman Foster, it's a sole member structure for all of the participating hospitals, I believe. So, but in our case, SVHC sole member is DH as opposed to the hospital itself. Because we wanted to preserve, it's a big board priority to preserve SVHC, which preserves all of our underlying foundation to raise money for our half of the cancer center and things like that. So it was very important to keep the resources that are charitable contributions that lower cost, obviously on the hospital side in Vermont and in our 3-state service area.
Thank you. That's helpful to understand. Does SVMC or SVHC have to pay any, I don't know what the right word is. Do you have to pay anything to the Dartmouth Health Network?
Bob, you want to?
Pay anything we do. So all of our physicians are Dartmouth Health employees. So we reimburse the payroll expense, but that's been going on for 12, 14 years, as Tom mentioned, as the affiliation developed. There also is some shared expenses, but we don't pay a fee to be a member to Dartmouth.
Can you describe all the various financial contributions that SVMC or SVHC provide to Dartmouth Health? And you can do it in follow-up if you want and just give me sort of a general overview.
There's no financial contributions from SVMC to Dartmouth Health. The only cash that's transferred between SVMC and Dartmouth Health is to pay for the physician's salaries.
And what about the shared expenses you mentioned?
There's no cash transferred for that.
Okay. So SVMC gets the benefit of those shared expenses for free?
It's on the P&L as an expense, correct? But there's no cash transferred for that.
But we do incur an expense, though.
Yeah.
Right.
Yeah. The expenses on the P&L.
Yeah.
About 1.9 million for fiscal 2026.
Okay. You have an expense of 1.9 for fiscal year 2026 to pay for the shared services you get from Dartmouth Health.
Correct.
Got it. And can you describe the shared services just a high level that you're receiving?
Sure. There's just a couple different buckets because we're not fully integrated. The biggest part is on our pharmacy, because the pharmacy as well as our supply chain areas are extremely integrated with the 340B program, as well as the formulary for our drugs in our pharmacy. Again, our purchasing and contracting in all the areas of our supply chain are also extremely integrated with the Dartmouth system. So there's shared costs there. New for this year, we have our biomed engineering staff are no longer going to be staff of SVMC. They're going to be Dartmouth Health staff, and those costs will be borne on SVMC's P&L through the shared service allocation. Those are the only three areas that we have expense Dartmouth Health shared services expense so far.
Okay, thank you. Follow up on the executive compensation. I just want to make sure I understood. I believe you said the top salary or compensation is 15 times something. Is that 15 times what? Multiple of that?
The lowest patient-facing employee.
it wasn't an average, it was actually the lowest patient-facing employee.
Correct. The lowest.
And what is the lowest patient-facing? What is the position?
It's our patient sitter. So a patient that an employee that sits with a patient.
Yeah, that's really hard work. It's a tough job. Okay. Page 17 of your submission, there was a list of drivers of expense growth that SVMC felt they should be held harmless in terms of calculating the operating expense growth. And I guess just a clarity question, when you calculated the operating expense growth for purposes of this submission, were any of these reduced? Okay.
They were all included. They were all included. The only expense that we excluded was the additional radiologist expense.
Right. Okay. Thank you.
Schedule.
And then as we look at some of the provider productivity, this is more of a transformation question, a little bit outside of your direct budget hearing, but a number of them do remain, considerably lower than I think where you'd want to see them. Are there any of these that you're looking at as to whether or not they can be combined with other hospitals or other facilities? And I guess part of that question, a double question. The other question is, are they low because you don't have the volume or because the providers aren't available, or what's driving the lower than benchmark on a number of these?
Sure, I can take that, or at least start with that. So first, I want to be careful that, Owen, that I'm not acting like I'm making excuses, but every single one of those has a lot of variables involved. So I'll just point that out and start with that. And I'd say that most of it is not volume driven. Maybe a couple of services, like maybe radiation oncology, we don't quite have the volume to support the 1.0, but most of them we have plenty of volume, especially like in primary care. And it's generally the inefficiencies that surround the physician practice and what those physicians need to do. So I'll just give a basic example. A basic example might be that in an efficient, well-funded practice, the physician is seeing the patient rather than making certain phone calls. And you've probably heard these statements before, but they're really true. And we did have a huge initiative, started probably 3 years ago. It was focused on primary care, and that did increase the productivity in most of those offices. And of course, it's not that the physicians weren't working hard, it's that they really didn't have the support structures in place. I do think some of those, I kind of mentioned one for gastroenterology. That individual, the gastroenterologist, sees lots of patients, but he doesn't do as many procedures right now as would be typical in a GI practice because he didn't have the support around him to see those patients. We're making those changes. So we should see those numbers go up. And then, it just, again, it varies from location to location and individual practice. I will say, though, your comment is right on when you said that if the productivity is low, does that mean the volume's not there and we should be combining those services? That's, for example, the plastic surgery that we gave the example for, that would be what we ended up doing, is that there just wasn't the volume to support that service. And there possibly could be others, but generally it's if the volume's there, then the practice remains.
Okay. And last question I have is, what's that interest rate on that $22 million line of credit?
Right. Our current interest rate is set at what the market is for a money market account. So it's a little over 4%.
And 22 million, is that the amount that you've accessed on the line of credit, or is that the total amount? That's what you've accessed.
That's the principal amount.
Yeah. Okay. All right. No other questions. Thank you all very, very much. And I believe Member Holmes is next if she has questions. Cat caught her tongue. we can move on to Member Teach Out in the event she has any questions.
Thank you. I have a few. The first one I wanted to ask was kind of narrowly focused, but it's on your bariatric surgery. And I was just curious that you are estimating an increase in that, especially with kind of the advent of GLP-1s and other avenues for people to address obesity. Can you just talk a little bit about your assumptions?
Trey, do you want to talk a little bit about the clinical side, and then we can talk about the.
Sure.
Yeah.
So you're correct. There, those medications and other changes have taken away from and reduced some of the surgical options. That being said, this group just got started with us. We know that there is a scarcity in that capital district of surgical access, and also in this area of Vermont. So that's why we're pretty comfortable as we look at the number of patients that are waiting for all of their clearance, like cardiology clearance, primary care clearance, that there will be an increase. Not a huge number of increase, but an increase, and we want to make sure to be, transparent, of course, in providing that estimate.
Thank you. I want to return, I think, to the slide that a lot of people have been asking you questions about. I think it's number, hold on, I have my note. The one where you show the charge master increase, the 20% increase on inpatient room and board, and then the losses you anticipate from H266. First of all, the 20% room and board increase seems significant. Can you talk about that, where that will put you in relation to, neighboring hospitals like Albany Med or facilities that you compete with?
Yeah, absolutely. So we've, finding the comparative data from a commercial standpoint is very, very challenging when you look at what's publicly available based on the different insurances. But we did do a manual analysis to look at that, and this will put us on par with some, slightly over on some, and under, and remain less than on several institutions.
So can you tell me specifically what that will make a room price per night and boarding per night, either all together or separately?
I'll have to look at. I don't want to quote a number that.
Okay, thank you. And then I did have concerns about the 6.8% charge master increase, and you're saying that your commercial rate won't go above 3%, the effective rate, even with this 6.8% charge master increase?
Correct. With the factoring in the reduction in the rate for what we paid on pharmaceuticals, as the 6.6 reduction in the rate that we're paying on pharmaceuticals offsets a significant portion of that.
Okay. The bill that passed, H266, actually has a provision in it saying that the hospitals cannot, that this is intended to be a cut, and hospitals are not supposed to offset the losses from 266. But I think I understand what you're doing with that now. So thank you. And then I did have a question about, on another slide, the one where you talk about slide 65, the majority of the investments are held at the parent organization. And I think that's in reference to your days cash on hand.
Correct. When we talk about parent organizations, SVHC, not Dartmouth Health.
Oh, okay. Thank you. I was confused by that. All right. And then I have the same question. I think it's very similar to what Owen just asked you, and It's quantifying the savings that you expect to realize through the integration with Dartmouth in the different areas across your organization. I think it would be helpful to see it all together. You did have the slide where you anticipate seeing the savings. So maybe just quantifying it on that slide. And I think that is it for my question. So thank you.
I'll turn to Member Walsh, and I'll just reference the statute that Member Teachout was alluding to, just so you have it. It is Act 55, Section B1. Quote, the purpose of this section is to reduce healthcare costs. A hospital shall not charge or collect from the patient or health insurer any amount for a prescription drug administered in outpatient or office setting that exceeds the amount set forth in Section A of this section, or increase the amounts the hospital charges for other drugs, procedures, tests, imaging, or other healthcare goods or services in an effort to offset revenue reduced as a result of implementing this section. Close quote. There is another section, though, that I should cite for you, which is B2, and it provides that if a hospital demonstrates to the care board in its budget submission that the price cap set forth is having a negative impact on access to care, the quality of care, or the sustainability of rural healthcare services, or a combination, the hospital may propose to increase the commercial reimbursement rates for one or more of its service lines, such as primary care, and the board shall consider both the demonstrated impact and the proposed increase to reimbursement rates. So I just wanted to flag that for you, but I'll turn to Member Walsh.
Can I just make one quick comment on that? The reason why we were making that request for an increase is directly related to our loss in 340B. Taking an $11 million reduction in our margin this fiscal year, in one fiscal year, and we've accounted for a significant portion of that through expense reductions, not able to account for it all. So we have extenuating circumstances for fiscal 2026. That was the reason why we enacted that portion, that section of B2.
Great. Thank you for clarifying.
Good afternoon, and thanks for the presentation. I just want to join my colleagues in a note of appreciation for the leadership and proactive approach you all have demonstrated over the years that I've been on this board. I do have just a couple questions. You've reduced administrative expenses more than most. Are there still areas in admin or non-clinical operations where you'd see potential for further cost reduction in the next year or two?
I would say yes. Tom, I think that's, I think there's more opportunities. I think it's going to require us to think outside the box more. And I think it's us working with the system, and also the potential. I have to be careful how I said this, but the potential of working within other hospitals, you know, in our regions. I think that creates other areas that we haven't really delved into yet. But the process that we're going through, the state process, I think it's going to help to open up those areas for discussion. So I'd say yes. If our longer term goal is to try to develop a sustainability on Medicare, that's going to require us to really think hard of how we do that. And Bob referenced this. We're using our premier staffing system that we've just implemented to look at where we think there's opportunities to be more tied to benchmarks of operations. So nothing's easy here, as we all know, and you know too. But I'm saying we're going to have to work hard to create a glide path that gets us to where we need to be, and we're not there yet.
And Tom, I think in addition to Tom's comments there, it's looking at, one of the problems, one of the challenges that we have, as we all know, is complexity, right? Complexity is just drives up costs. And how can we reduce that complexity and automate certain services. And we're definitely focused on that. Standardization leads to reliability, and simplification is what reduces costs.
Yeah, thank you both for your honest reflections on that. I do know that it's a very difficult process, and I know in years prior you've alluded to high reliability organizations and principles and adoptions of some of those. And Tom, you mentioned looking at how your cost structure is relative to Medicare reimbursement. That reminded me of a guest speaker we had just this last spring in the Medicare break-even program in Ohio. So, and the lessons that Dr. Pronovost spoke of there was it takes numerous cycles of looking. And so I appreciate your candor with that.
I will tell you, Tom, we brought in Peter Pronovost here 10 years ago. And we spent a couple of days with us going through these opportunities, and he was enlightening. Now, I will also say that that's what's also making us look at the Medicare reimbursement, because every state is different, every hospital is different, and the hospitals in Cleveland, in particular, his hospitals, 4 times our reimbursement rate for Medicare. So that's sparked an interest of why is that so, and we're trying to delve into fully understand the difference of Medicare reimbursement. I think Vermont's getting the short end of the stick, and I told that to Senator Welch and Senator Sanders recently. But that being said, that's what we're trying to strive for, and it's a challenging journey. But I think working within a system approach, I think there's more of a possibility to do it than on our own. I think on our own would be very, very hard.
Yeah.
I'm not sure how we would do it on our own, to be honest.
Yeah. Regarding the adequacy of the Medicare reimbursements, I think I understand where you're coming from, and I think looking at other places and seeing that difference place to place, I'd be doing the same thing if I were in your position. I think one of the things that I try to think about and we try to think about, and I'm wondering if it sounds as though you all are also thinking about it. If the payment is felt to be inadequate, then the other side of the equation are the costs, right? And doing everything that you can to reduce those costs also improves that ratio, right?
Oh.
And so you're doing it. You see there's more available. I think that's excellent. Trey?
Yeah, Tom, you just gave me a segue to say where are a lot of those costs are at the end of life, and that's an opportunity for some savings right there.
Okay. Regarding the system and the partnership that you've spoken so well about, I wonder if you could help us understand how your leadership and board leadership, and Tom, thank you so much for being here. I think it's wonderful. I hope we see more of it across the state and in future years. But I can imagine that at some point there could be tension between what kind of the priorities of the mothership and the community needs of the local affiliate. And I wonder how you've struggled with thinking about how you'd address that or reconcile it, even if it hasn't happened yet. How do you consider dealing with that?
Well, Tom, why don't I start just from the board level on that? Well, we were together in various roles for 12 years before the July 23 full membership. One of the things that the board did, working in concert with obviously our team led by Tom and the Dartmouth team, was to come up with a joint analysis of where the organization, once we were a member, should go. And we used Chartis for that. And that's where some of the major initiatives that we're implementing came from. it was certainly heartening to have Dr. Hammery working for Oliver Wyman, working for all of you, come to many of the same conclusions on the cancer center expansion, on what we need to do in primary care, on what we need to do to reduce out-migration and deliver more care closer to home at lower cost. And so my experience, and I am on periodic meetings with every one of the other board chairs. We have periodic meetings with the leadership at Dartmouth. We've worked very hard on the board composition to ensure that there's pure alignment there on the strategy. So, well, I do anticipate, Tom, over time, there'll be places and times when that's not true. That right now, I'm feeling very good about that. Well, we lost Kathy Fisher because she termed out after 9 years. We got Dartmouth without any effort needed by us to put her on the system board. So Kathy Fisher is now on the whole Dartmouth system, the parent of the parent, if you will, board. And we have Dr. Ed Merrins, Chief Clinical Officer on our board, Steve LeBlanc, Dr. Conroy's right arm on our board. And we have another member coming in, I won't name because it's not public yet and that she hasn't started, but it'll be great alignment between SVMC and DH at the leadership level of the board. I'll let Tom speak about management, interaction, but mine is pretty frequent with the leadership of both the other hospitals and of the system.
But I appreciate that, and I think what we're probing, I think Dr. Merman, Chair Owen, what we're probing are these areas where we see that the benefits of the system integration that are promised. What we're seeing across the country is that it hasn't always borne fruit, and we haven't seen the improved care coordination or the decreased costs. We've seen higher prices, and we've seen misalignment with communities. And what, at least what I'm trying to do is question the readiness to look for those things if they start to go in the wrong direction. Because I think there can be partnership with us, that you're trying to do the right thing, we're trying to do the right thing. But if it starts to float toward national trends, how do we pull it back? And it'd be great to have your help with that. And those are the type of things that we'll be looking for.
I would distinguish just conceptually, Tom. And I used to be a banker for some of the systems, including one of the ones in Boston that was rolling up suburban hospitals. And that's a different model. That there's a lot that happened that led to the data you're looking at, where volume went in to the mothership. That's the opposite of what Dartmouth Health is doing with their more recent community hospitals. And it relates to Tom D's reference to regional referral hospital. They're more than full all the time, and they are sending volume to other member hospitals. And we're enhancing our clinical, slate in order to be the bigger recipient of that. And they're also dedicated to rural health for the northern New England region, reaching down into northern Massachusetts. So I do think the data is probably generally comprised of urban parents that have rolled up the suburbs, and that leads to a different dynamic.
Well, again, I appreciate all that you're all doing, that you've done, your leadership, proactive approach. And I appreciate the optimism that you have about this, and look forward to continuing to look at things with you all.
Hey, Tom, can I just add
Please,
a couple of points to what you're raising? Because you're raising healthy skepticism, and I get it. And listen, my prior life, I've been in some bad arrangements with systems that were exactly what you're saying. This is early on, but yeah, we had 12 years in affiliation together. But I will say Dartmouth is different. But talk is cheap. But I'll give you two examples of things that they're supporting us on, and it's not going to make money. It's all about community need, and it's about the vision of what we need to be. And the one is, and Trey talked about the family medicine training program. That's a heavy lift. And they are stepping up to be the sponsor of that and really helping to underwrite that program, because they see a need in Vermont for additional primary care access. And this is not about making money. This is about providing a critical need that's, we just can't address on our own. We could never do this on our own. And the other one that I don't believe we could do on our own, and you all have been very supportive, and I appreciate it, is the advent of the mental health services. That people were not running to the join up to do that service. I got to tell you, and it took some leadership from our board, leadership from Dartmouth to say it's the right thing to do. Let's do it together. And again, we could never start that service. We would never recruit the psychiatrists and the other professionals to make that work. And those are two examples of the mothership working with the member hospital and say, let's do the right thing. Let's make this work. So, and there's numerous other examples I can point to. So it's early on. We're just scratching the surface. This is a long haul. But I think there's real opportunities to work together, and I know you're going to hold us honest to it. So,
I think I appreciate the examples that you point out. I'm very appreciative of bringing the inpatient adolescent mental health care to the region. Very important work, and I do believe you're right to point out it is a healthy skepticism. I also have an optimistic side that thinks you have an opportunity to show how this can be done well. I've seen it done well other places. It can be done well. I think we've got to watch out for the things that need to be watched out for. So,
and I think we're looking at other rural systems across the country to see how they do it and look for best practices. And I think and we'll learn from it. I know we'll stub our toes too, but I think we can learn and do some very good things here.
Thank you all very much. That's all that I have.
Any questions, Member Holmes?
I do, and sorry, I couldn't get my teams to unmute, so that was my flailing around. Anyway, I have to take just a couple of seconds and just again thank you, Tom, Mr. D. Seriously for your long, very, very mission-driven service to Vermont. I've always respected, as a longest-standing board member, I can tell you, you and I have worked together for 10 years, and I've always respected the ways in which you've led your hospital with incredible integrity and all the innovation you've done. So I just have to say that you're going to be missed for sure.
Thank you.
Yeah. I do want to ask about this rate request, and I just want to get from you all, with this 6.8% requested increase in the charge master, what is going to be the average increase in rate that you would expect the self-pay to experience?
Yeah, that was one of the reasons why our bad debt and charity care we've increased by 1.5 million over what we're projecting this year, was to help offset the self-pay. So we did not anticipate any increase to our self-pay population in this budget.
Okay, but so there's no increase in rate for the self-pay? Is that what you're saying, 0% rate increase for the self-pay?
We anticipated not collecting. We charge all of our patients the same charge for every patient, just like every other hospital does. But we're not anticipating collecting additional reimbursement from the self-pay group. Our self-pay population is a very small population of our community as well.
Okay. Just as a border hospital, can you just remind us what assumptions you're making about Massachusetts, New York, and Vermont Medicaid rate increases?
Right, we have 0 increases in Medicaid rates across all 3 states.
All 3 states, okay. And then I just want to echo some of my colleagues who are asking questions about the radiology transfers. I would echo the request to kind of review that Schedule A. I think the exact
offsetting revenue and expenses is odd down to the dollar. So if you could just do that, we'll look at that again. I also noticed that you had 5 radiologists in the prior year as well as in the current year. And I thought I heard you testify that you've increased the radiologists by 1. Is that right? So there's 5 now?
Yeah,
Right.
there's 5 individuals. One's been very, very part-time, reading only mammography. And he did not join this group, but he has been contributing like seriously like a 0.1 FTE. I mean, he's served for 40 years, but he's retiring. And so it is a larger number of FTE component than bodies.
Got it. Okay. And I just wanted to ask too, it sounded like there, with the hiring of an additional FTE, actual, clinical FTE with hours, and the increase in number of procedures that can be done now with the incorporation and the transfer, it would be helpful to understand what is the increase in revenue that's expected from these additional procedures and additional full-time provider, and the expense reduction that's associated with having no more third-party readers. I think that would just really be helpful to understand there.
We can do a schedule of what's included in our budget assumptions for those 2 pieces.
That would be fantastic. Thank you. And I know that some of this has been addressed in the presentation, but I wanted to ask anyway, compared to 25 budget, the only planned service eliminations for fiscal year 26 are plastic surgery and at least a temporary sunsetting of pulmonary rehab. Is that right? You're confirming that's the only planned eliminations for fiscal year 26?
As well as the clinic that we have on Mount Snow.
Right. Okay.
The part-time.
Thank you. That's great. I forgot about that one. And are you planning any reductions in services? And again, this could be, just reductions in clinical capacity, hours, numbers of sessions, number of days open, anything like that across any service areas.
No.
I don't think so.
I can't think of any.
Okay, great. Just wanted to clarify. You are increasing services. There's a couple areas, right? You've talked about inpatient dialysis, primary care, cardio, cancer, et cetera. And the narrative cites 12 additional clinical FTEs. And I just wanted to point out and maybe ask if you could relook at the clinical productivity table. The clinical productivity table has a column for changes in the budgeted clinical FTEs. And I noticed that there was no change in the budgeted clinical FTEs for primary care, but it looked like there were reductions in the budgeted clinical FTEs for cardio and medical oncology. So just wanted to double check that I'm seeing that correctly and that in fact there are increases in those areas of cardio and medical oncology anticipated.
Yes, we'll take a look at that.
Okay.
One thing, just because we don't budget for people we haven't hired. So for example, we know we need another oncologist, but we don't obviously put that in the budget. I think that's self-evident, but I just want to make sure that to point that out.
Okay, great. Maybe if you could just check it out and look at it. I think
That'd be
even the
great.
primary care where you have budgeted, I believe some of those 12 clinical FTEs were coming from primary care, yes?
Okay, we'll take a look. We have in the past budgeted when we think we're gonna get someone, but we've just decided that's not a good practice, so.
Okay. And my last question, given the time, hopefully I'm fast here, but is, you have been a state leader in adopting many of the Oliver Wyman recommendations. I appreciate that, taking that report seriously and taking seriously care transformation efforts. Can you share any potential opportunities that have been identified in your work with RHRC that maybe are not showing up here yet, but you are considering?
They're coming in to meet with us again, Jessica. So it's early on in a sense. So I have to be a little careful because I don't, I think one of the things they're talking about is, how we can potentially work with other hospitals, and we're interested in that discussion. So, so I wouldn't say, I can't point to one that I could put in the budget right now in terms of next year, but I will say we're open to all thoughts and ideas, and they're welcomed. So, but it's still probably a little too preliminary for me say, yeah, this is a great idea. And that's not a shot against them. I just, it's just not there yet. So
Will you share what their recommendations are with the board? With us, the board, Green Mountain Care Board?
oh yeah,
Okay, great.
we have no problem doing that. Yeah.
Thank you so much. Those
Yeah.
were my questions, and I appreciate it. And thank you to the whole team. I know there's a lot of work that goes on in putting these budgets together. I appreciate it.
Thank you.
Mr. Sutter, did you still have a question?
I did. Just a quick one. I apologize if this has already been answered, but I was curious, any drugs you purchase that are affected by H.266, are any of those purchased at a cost greater than 120% of the average sales price? If you guys know that offhand, I was just curious.
Hmm.
The majority of them are purchased higher than 120% of average sales price.
Thank you.
We'll be losing significant margin on our infusion practice, especially when we lose the ability to purchase those drugs on 340B.
Thank you.
Mr. Lubbock, would you mind providing, and maybe you have and I didn't see it, but would you give us a breakdown of the drugs that you purchase at above 120%?
I will look to see. Yeah, I'm pretty sure I have that analysis. If I don't, it might take a little while to get it, but I will work on it.
Okay. If, we generally have a lot of follow-up on that one. If you're having difficulty with all the requests we have, we can prioritize. So let me know. Okay.
Our system doesn't link the purchase and the modeling of the 120% very well. So I will work with the staff to see if we can do that.
Done manually. Yeah.
Yeah, it'll be a manual process. Yeah, absolutely.
I see. I'll turn to the healthcare advocate.
Nothing from us, Chair Foster. Thank you.
Thanks. And is there any public comment via raise the hand? Okay. Hearing none, thank you all again. Is there any new or old business for the board? And I will move that we adjourn today's hearing.
Yeah.
Second.
All in favor, say aye.
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 Aye. All right. Thank you, Mr. D, and everyone have a nice afternoon.